Hello.
How's it going?
Good.
Everybody's excited to be here. So, I think today we are going to finish up with diuretics, and then I think we'll take a mental break and do a quick exam review, and then we'll go to the heart attack, right? So myocardial ischemia. All right, so, and I finished up on carbonic anhydrase inhibitors. Remember, these guys, again, don't really get used as diuretics anymore, but since the carbonic anhydrase enzyme is found places like the eye, they can get used for other purposes, like for glaucoma. But just briefly, how these guys work, if they were to be used for as a diuretic, would be, again, the carbonic anhydrase enzyme is located on the membrane and the lumen side, right? So the urine side of the tubule system, and we're at the proximal tubule here. So, and that converts carbonic acid to CO2 and water, which then get pulled into the interstitial space, where they get combined again back to carbonic acid over here, and that carbonic acid breaks down again. The bicarbonate gets kicked out into, or reabsorbed into the blood. So the carbonic anhydrase inhibitors block this effect, right? And so, among other things, you're not going to be reabsorbing sodium bicarbonate as much, so you can get issues there. Okay, next type of diuretic I want to cover are osmotic diuretics. You guys are working kind of a pretty simple way, actually. So they work by diluting the filtrate and reducing the reabsorption of ions. So what happens with these osmotic agents is when you take them in, then the actual osmotic agent gets filtered at the glomerulus, and it's stuff like mannitol, glycerol, gets filtered at the glomerulus, put into the filtrate, but essentially what you're doing with these guys is diluting the filtrate, so diluting the stuff that's in the lumen, right, the urine side, and so with that dilute, it's basically just harder for enzymes and supporters, et cetera, to pull sodium, et cetera, out and reabsorb it, okay? So these are basically inert substances, and their major site of action is going to be at the loop of Henle. They also do have some actions at the proximal loop. In addition to diluting the filtrate, they have some other actions. For instance, they can expand extracellular fluid volume, decrease blood viscosity, and they can inhibit renin release as well. And also this other main point here is that they will extract some water from intracellular components. Okay. Again, the big point MOA with these osmotic diuretics is they get into the filtrate, but then they aren't reabsorbed, so they cause the percentage of sodium in the filtrate to go down, because you've also got the osmotic diuretic there, something like glycerin, mannitol. Okay, and so you have this dilute filtrate, and so sodium doesn't get reabsorbed. And down here on the slide, it shows some of these different osmotic agents that can be used. And this slide just kind of highlights where these osmotic agents have their primary site of actions and secondary site of actions. So, and it's got this little star here at the afferent and efferent tubules, right? So here is, these agents get filtered out, right, into the filtrate, but again, they're not going to get reabsorbed. So there's one side of action. They're also, again, at the loop of Henle, they're causing the filtrate to be more dilute, as it were, so less sodium in there. And so you're not going to get reabsorption so much. And then there are some actions at the proximal tubule. But really the big area, where they're really stopping the most reabsorption is going to be in the loop of Henle. Okay, moving right along. Speaking of loops of Henle, So going to loop diuretics or high ceiling diuretics. These guys work, of course, at the loop of Henle. And what they do is pretty simple. They inhibit the activity of the sodium potassium 2-chloride symporter at the thick ascending limb of the loop of Henle. And more specifically, what they're going to do is they're going to block chloride binding to this symporter. Essentially messes up how it works, and so sodium, chloride, etc. are not going to be reabsorbed like they normally would. These guys work well, almost too well, really. That's why they're called high ceiling diuretics. And one reason they work so well is because of where they work, the loop of Henle, right? So if you were to try and say block a sodium transporter, you know, a proximal loop, you might do that, but then the sodium would still get reabsorbed down the road in the loop of Henle, etc. So trying to block reabsorption, you know, the proximal tubule, or even to a lesser extent the distal tubule, that doesn't work as well as blocking it at the loop of Henle. Okay, so overall, these guys are going to increase the urinary excretion of sodium and chloride. And I actually removed like one slide from the original diuretics PowerPoint. So if you downloaded this a while back, you might have a missing slide or an extra slide in your slide set. But don't worry about it. Okay, so anyways, these guys are going to, by blocking sodium chloride reabsorption, of course, you're going to get increased excretion of sodium and chloride. Another thing they're going to do, and this is actually important, is, you know, when they're blocking this reabsorption of sodium and chloride, they're disrupting the electrochemical gradient, trans-epithelial electrochemical gradient, and so that actually causes increased calcium and magnesium excretion as well. So normally those guys would follow an electrochemical gradient and be reabsorbed, right? That's not going to happen because you messed up the electrochemical gradient at the loop of Henle, so they're not going to be reabsorbed as easily. So you're losing all these potentially important ions as well, which is why these agents have to be used carefully. And as the slide says, some of them also have carbonic anhydrase inhibitory activity. And another important point is they can cause increased potassium and hydrogen excretion due to causing an increase in sodium at the distal tubule, sodium in the filtrate, which again is going to mess up your normal electrochemical gradients. So you can get too much potassium loss with this as well. Okay, another action of these loop diuretics that you should be aware of is they can actually increase uric acid reabsorption. So at least initially you can get this increased chance of gout. However, long term you're going to get a reduction in uric acid secretion. So if somebody has gout, you want to be careful using a loop diuretic. Again, like other diuretics, their actions are going to be attenuated by NSAIDs, non-steroidal anti-inflammatory agents. So NSAIDs reduce renal blood flow. You guys remember why NSAIDs reduce renal blood flow? Yeah, they inhibit prostaglandin production. Prostaglandins have a whole bunch of effects in the body, and one of those is prostaglandins help regulate blood flow to the kidney. And prostaglandin E causes like vasodilation at the level of the kidney. So loop diuretics can also stimulate renin release, because you're, of course, decreasing sodium, right? Decrease sodium, and that's remember the macula densa pathway of renin, stimulating renin release. So you lose sodium, you're going to get an increase in renin release as well. And so renin angiotensin system activity is going to go up with these. In terms of other effects that you may want to be aware of, these guys are hypothesized anyway to have some direct vascular actions, and so they increase venous capacity, and this effect is thought to be mediated by prostaglandins, and it actually can be helpful to people with pulmonary edema. So somebody's got a bunch of extra fluid on the lungs, loop diuretics might be the best way to go. Okay, and in particular, furosemide will do Okay, really simply here, this slide shows the sodium chloride reabsorption and the loop diuretic mechanism of action. Again, we're at the thick ascending loop of Henle. Okay, and here's this, right here is the sodium chloride, sodium potassium 2 chloride symporter that's pulling all these sodium chloride and potassium all the same direction from the filtrate, where it's eventually going to get reabsorbed over in the blood. So you're blocking the activity here, okay, and more specifically blocking chloride binding there. That messes everything up. The other thing that can happen too, though, is again, when you're doing this, you're changing the electrochemical gradient, along the membrane here, and that's going to influence calcium and magnesium reabsorption. So that's not going to happen like it normally would. So you're going to lose those ions as well. So obviously, the potential to lose a lot of ions, these things need to be given and monitored carefully. This slide shows another way of looking at that. Just another it's from like cat sun, but this just shows over here is the lumen side, and it shows that this is the sodium potassium 2 chloride symporter is supposed to be this guy here, and the chloride binding is blocked. The thing doesn't work right, so sodium and chloride, etc., it doesn't get reabsorbed normally. Okay, in terms of adverse effects, the adverse effects of these guys are going to be due to the fact that they work very well, and in particular, you can cause too much ion reabsorption, so you can cause electrolyte imbalances with loop diuretics. And you can also get this major depletion of total body sodium that happens, which is hyponatremia, not enough sodium in your body. That, of course, going to be problematic. And can even go to the extent of causing circulatory collapse. So he's taking too many of these things. Another kind of interesting thing that loop diuretics can do when they're given actually IV is they can cause, and this is a little bit weird, ototoxicity. Right? You guys know what ototoxicity is? You guys heard of this one? Okay. So ear damage, right? And this shows some chemical structures for anybody interested in chemical structures. Has Tavarish gone over this stuff with you guys yet? Yes? Okay. All right, moving right along. Thiazides. Thiazide diuretics get used a lot, and they get used in combinations with other drugs like, for instance, ACE inhibitors. So how thiazide diuretics work is they inhibit sodium chloride symporter in the distal convoluted tubule. So we're going all the way down the tubule system, getting closer to the collecting ducts. So what happens is, under normal conditions, this sodium chloride symporter uses a sodium electrochemical gradient to transport chloride and sodium from the filtrate into the membrane, and then that goes against its own gradient, and then by way of sodium potassium pumps, that sort of thing, the sodium then gets reabsorbed into the blood. So thiazides block that symporter. Okay, and by blocking that symporter, they're going to increase sodium and chloride excretion. And since this is at the distal tubule, the net effect on sodium is going to be relatively modest, so it's not a huge effect, but it does occur. They also can cause an increase in the excretion of potassium, which can be problematic. And why this happens is when you increase the amount of sodium that reaches the collecting ducts, sodium potassium pumps there get stimulated, and they exchange more sodium for potassium than usual. And you guys remember these sodium potassium pumps from things like neuron electrophysiology, right? Kick out exchange 3 sodiums for 2 potassiums. So these things can be stimulated in the collecting ducts, and you wind up losing potassium that way. They can also indirectly stimulate aldosterone secretion, which also increases the activity of that sodium potassium pump, so you can increase potassium loss that way. And those are the main points, really. And here, just the Goodman and Gilman slide shows thiazide mechanism of action. So what they do is they block, once again, we're in the distal convoluted tubule, So we're blocking the sodium chloride symporter here, so you're not ultimately not getting sodium and chloride reabsorption like you normally would. Instead, it's going to pass down and be excreted. Got it? And this is another way of looking at it, another depiction of what's going on with thiazide diuretics. In terms of adverse effects, these guys can cause increased erectile dysfunction as compared to other agents that get used as antihypertensives. As you would suspect, you can get fluid and electrolyte balance alterations that might not be helpful. So you can get extracellular fluid volume depletion that occurs, and they can cause hypotension. They also can cause some impaired carbohydrate tolerance. So hyperglycemia can occur with thiazide diuretics, and exactly why this occurs is not really that well understood, but it's thought to possibly involve some decreased insulin secretion. Okay. They can also cause hyperlipidemia. All right. In terms of drug interactions, of course, thiazides are going to get prescribed, I think, fairly frequently. So you want to know these. They're going to lessen the effects of anticoagulants, uricosuric agents, so agents for gout. Then they have also insulin and sulfonylureas. They can actually increase the effects of anesthetics, lithium, loop diuretics, and vitamin D. All right. So they can actually increase the amount of those guys that are increase their reabsorption gets altered. Okay, and then there's an interaction that can happen with quinidine that actually can lead to ventricular tachycardia. And it's thought to possibly be due to the excess loss of potassium that goes on with these guys. And here's just a long list of different thiazide agents. When I ask questions about thiazides, I'm going to ask that as a class. And I'm going to ask, of course, what part of the tubule system do these guys work at, and their relative effectiveness compared to, say, loop diuretics. Okay, next up, in terms of diuretics, are potassium-sparing agents. And the first ones we'll go over are sodium channel inhibitors. And these guys are going to work mainly distal tubule, right? Distal convoluted tubule. So triamterene and amiloride are currently in use. Amiloride is the best study. So these guys are working way down distal tubule collecting ducts, and they're blocking the sodium channel there, as their name indicates. And their main use is actually to reverse potassium loss that gets caused by other diuretics. So sometimes somebody's taking like a loop diuretic or thiazide diuretic, and they're having a lot of potassium loss. You actually give them another diuretic to spare that potassium. But overall, they do also cause a modest increase in sodium chloride excretion. Okay, and again, these guys work by blocking an epithelial sodium channel in the collecting duct and tubule. And these ENaCs, or epithelial sodium channels, are located on the lumen side, so on the filtrate or urine side of the tubule. And among other things, when they block this, they're going to attenuate the negative electrical potential of the membrane, and by doing that, they're actually going to stop the excretion of potassium. So they're going to stop potassium from coming back out from the blood and being put back into the filter, back into the urine. And they also, by disrupting the membrane electrical potential, they're also going to decrease the excretion of hydrogen, calcium, and magnesium. So they're going to spare these ions. Okay, in terms of net overall effects, sodium and chloride excretion gets increased, but it's a pretty small effect. With these potassium-sparing diuretics, the sodium channel inhibitors, they might actually decrease uric acid excretion, so somebody taking these may develop gout. It's potential. In terms of adverse effects, of course, you're sparing potassium and it's not being excreted as much as normal, so hyperkalemia could be stimulated. Too much potassium in the blood is a super bad thing. It can be life-threatening. Okay, and this is more likely in somebody who's already has impaired kidney function, or somebody who's taking other potassium-sparing diuretics. I don't know why you would do that, but I suppose it happens. Also, somebody taking NSAIDs, again, NSAIDs can alter blood flow to the kidney, or somebody's taking potassium supplements. You can overdo it with these. They also are associated with nausea, vomiting, diarrhea, and headache. I don't think those are necessarily kidney-specific effects. Okay, and then triumphurine can reduce glucose tolerance and also cause some photosensitization. So somebody might become sensitive to light taking this. Okay, there's the main points there. Sodium channel inhibitors, again, we're at the late distal tubule and the collecting duct where these guys work, and they're blocking the sodium channel here. So you're blocking sodium reabsorption here, and among other things, then you're changing the electrophysiology of these membranes, and so among other things, you're not going to get this potassium excretion that's normally going to go on. You've altered the normal function there. So the potassium is going to be spared to stay in the blood rather than get passed out into the urine. Okay, same way. This is essentially the same information on a different slide. Okay, and last but not least, everybody's favorite, mineralocorticoid receptor antagonists, which are also potassium-sparing diuretics. The two mineralocorticoid receptor antagonists that get used are spironolactone and eplerenone. Okay, and I hope I pronounced that right, but I probably didn't. Okay, and these guys are going to block the actions of aldosterone, so mineralocorticoid that thing. Okay, sorry. This is dry material. I don't know how to make this more interesting material. Maybe I can dress up like a kidney next year. Tubule system and have kind of lengthen it out and drag it around. I don't know, but any suggestions, let me know.
I like that.
What, the kidney thing? Yeah. Well, but we're going to go into myocardial ischemia next, so maybe I'll dress up like a heart.
Yes.
And then I'll ask you what muscarinic receptors are on me. What is the answer to that? M2. Yeah. Okay. I'm a little late though. Valentine's Day. Well, anyways. Okay. Mineralocorticoid receptor antagonists. You guys remember mineralocorticoid receptors? I kind of see a little bit of blank faces out there, but these guys are nuclear receptors. They're related, of course, to glucocorticoid receptors. Okay, and what happens is these guys are found unbound, floating around in the cytoplasm of cells, particularly in the kidney. And when they get bound by aldosterone, they translocate into the nucleus and form dimers. And then the dimers are going to interact with hormone response elements and other transcription factors at the level of the DNA. So when we're talking mineralocorticoid receptor antagonists, they're working through the genetic machinery to cause changes in function. And among other things, does that mean they work super fast or super slow?
Slow.
Slow, right? You have to get transcription changes, translation, etc. So when somebody's taking these, you're not going to get this immediate effect. Okay. But what happens when mineralocorticoids are normally activated, they get this activation of specific sodium channels. They're the same sodium channels that the sodium channel antagonists go after, these amiloride-sensitive sodium channels. They also result in the activation of the sodium-potassium pump. Okay, and so you're blocking this effect, and by blocking this effect, you have some diuretic effect, but you're also sparing potassium. Okay. So this slide shows the aldosterone mechanism of action. So over here, animated this aldosterone, and made it a triangle, a red triangle. So when aldosterone gets secreted, where does it get secreted from? I needed this break anyway. So the adrenal cortex.
Oh, adrenals.
Right? What stimulates it? Its release. I think we lectured about it on like Monday. Angiotensin II, right? Among other things, going to stimulate its release. So aldosterone now at the level of the kidney is going to bind these mineralocorticoid receptors, which are going to translocate from the cytoplasm into the nucleus, right? They form dimers there. They're going to bind response elements on DNA. You're going to get alterations in transcription. And among other things, you're going to get the stimulation of these sodium channels. So you're going to get this insertion of more of these sodium channels on the lumen side, okay? And we're talking down, collecting ducts, distal tubule here. Okay, so you get more of these sodium channels. They're activated, so you get sodium reabsorption with this, and also you get activation of this sodium potassium over here. Okay, so in that effect, when this system is working normally, right, is you get more sodium reabsorption, but when you antagonize it, then you get less of this going on. So you get less sodium reabsorption here. And you're also going to get, you'll spare potassium, because the potassium is not going to come from the blood and be put back into the filtrate. So you spare potassium in the blood that way. Got it? Here's just another way to look at it. And that's diuretics, and that's most of our renal stuff for pharmacology. I like this slide because it shows all the diuretics you've ever wanted to know about, as well as where they work in the tubule system, in the kidney, et cetera. So if you can go through this slide and you understand how carbonic anhydrase inhibitors work, with diuretics, Thiazide-Diuretics, and then there's potassium sparing agents, you'll be golden. So if you know this slide, you know everything you need to know, pretty much, at least in terms of their basic mechanisms of action. Okay, and in the study guide I put up, there's stuff like this to fill in. So you might want to look at that and go through that as you're studying. And that's the end of that. Yay. Okay. No, I don't.